Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today, and our friends at Interprofessional Community Clinic for hosting today's session, Pelvic Health for the Transgender Male, with our presenter, Debb Dunn. Deb is a family practice physician assistant at the Trans Health and the Trans Health coordinator of the LGBT Resource Center for Chase Brexton Healthcare in Maryland. In addition to graduating from Howard University's Physician Assistant Program, she holds an MBA from Johns Hopkins University. In her position at Chase Brexton, she provides leadership and coordination of care for transgender identified patients, establishes best practices for medical transgender care, trains our other medical providers, provides consultation to external organizations on transgender related issues, including employee transition, engages in advocacy at the state level, and identifies research and funding opportunities related to transgender care. We're so very lucky to have her as a MAVEN Project speaker. So Deb, when you're ready, please begin, and hopefully you do not get as tongue-tied as I just did.
Oh, good afternoon. Thanks for inviting me. I would like for folks to put in the chat what your job role is, so I can make sure I address everyone that's watching today. Debb Dunn, PA, been expertise in transgender medicine for 15 years now for the adult and the child. I'm part of a team that wrote a program for the treatment and management for transgender children, Gender Joy, Journeys of Youth. Again, national speaker. And what I'd like to also say is I know that a lot of the stuff I'm teaching you today, you are not going to have learned anywhere. And I really don't mind if you ask questions throughout the presentation, so I can just roll it right into the presentation. So pelvic health, good. Medical student, good. So I'm guessing that most of you are medical providers. Midwife, good. Oh, I'm so glad to see GYN people. Oh my gosh, thank you so much. We need you. All right. So first thing I'd like to do is really just start, well, first of all, I've got to do the disclosure. None of the individuals in a position to influence the content for this educational activity have a relevant financial relationship to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. All right. MAVEN Project is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. So first thing I would like to do, probably in the first 10 minutes, I would like to, I usually go through how patients who are trans-identified like to be addressed in the office. So I'm going to let this group of trans-identified adolescents teach you that, so you can have a personal testimony from them.
What pronouns do you use, making your appointment? I feel like that would be a little bit too in your face.
Have you ever encountered problems filling out forms or like frustrations with having to like check certain boxes?
Yes. That male female box, that yes, because I want to mark female and legally I can't, and that irritates me. Or I might be on the phone with them and they may say, well, what is your gender? And I have to tell them what my legal gender is, but that really frustrates me. It does.
Do other folks have similar experiences with that, or different experiences that you would want to talk about?
They actually asked for your preferred name, and I put it down. I was like, yeah, they're going to use it. And they didn't, and I was like, so what was the point of me putting it down if you're not gonna? So yeah, I get that there's the good intention, but you're not gonna implement it. There's no point of putting it there.
If you could list off just 5 words or terms that you would like your healthcare providers to know or be comfortable with, and do some education on their own about, what would those words be?
Those would probably be cisgender,
transgender, gender nonconforming, cis sexism, transphobia.
Cool. So just learning those things would be good.
Yeah, oh my goodness, please learn them.
So cis or cisgender is someone who identifies as the sex and gender that they were assigned at birth. So that's when the doctor like sees the baby and they're like, oh, it's a boy, or oh, it's a girl. They still identify as whatever the doctor said at the time.
I'm not big on terms. I just like for people to be respectful. As far as like, if you don't know, pull me to the side and ask me. Or if you think you know and may have an idea, still pull me to the side and ask me. Don't be like, oh, well, she looks like a she is, or is she a he, or don't try to guess it. Like I said, I'm not really big on using terms. I just use female, and I may ask you, or I rather just use your name. You don't know what we're.
Okay, I'm gonna stop there, but the point is, find a system. So I walk in the room. Hi, I'm Debb Dunn. I'm a PA. I'll be taking care of you today. Can you tell me your chosen name? We're not saying preferred name, or sometimes I'll say the name you want us to address you by. And then let them tell you it may be very different than the name on the insurance card. So make sure you're not going like out in the waiting room in places and calling back people by their dead name or the name that was given at birth. What happens is it can trigger their dysphoria. And dysphoria, is that thing that when they look in the mirror is really not lining up with the way they feel on the inside. And it can be anywhere as like the one person said, I really no, terms don't really matter to me, to a person wanting to go home and die from suicide. Because why did you see a man when you saw me? I am a girl. I am a girl. And on your forms, always make sure there's a place where people can really put the gender that they identify as. All of these are very affirming. Just until then, just think gender neutral. Like you're not brothers and sisters, your siblings, their children. You're not going to walk in a room and look at a person and say, "It looks like you brought your wife. Who's the wonderful person you brought with you today?" And let them say, "It's my wife or husband." So we're going to say spouse. Tell me about your family history. Tell me about your parents. Well, my mother has hypertension. And then you're going to say, what about your other parent? You're not going to assume the other parent's a father. And then let them say, well, my father has diabetes. Keep in mind that pink sometimes can be a trigger. So if your gowns are pink, ask permission. I had a person that tore it up right in front of my face and said, did you think I was a girl? Why did you give me pink? And deep voices when you answer the phone, that's not masculine voices, so forth and so on. And make sure you're not caught up in gender expression, because you can't look at a person and tell what their gender is. I just finished seeing a young 17-year-old who identified as male, assigned female at birth, but just beautiful, long eyelashes and makeup and skirt and halter top. So just don't assume that based on expression. Don't look at breast and say, excuse me, ma'am, that kind of thing. And you'll do good. So some basic terms, I am going to use terms like AFAB, assigned female at birth, and AMAB, assigned male at birth. Just like the person in the film said, you're born, the provider sees a penis, you're a boy, so forth and so on. What I honestly believe is that people know their gender from birth, but they were assigned the wrong sex at birth. They're not trapped in bodies. They aren't boys trying to be girls, so forth and so on. And gender neutral terms, we're going to go over some terms when I teach you a little bit about physicals. But I just kind of want to go over sexual orientation real quick. And the reason why I put adolescent here is because we now know that age 12 to 24-year-old is the group in the LGBTQ that are we're seeing a big rise in HIV. In fact, higher than any other group of people. Like CDC just came out with their report recently, and the 12 to 24-year-olds had way surpassed anybody over 25. And why do I think that is? I think it's because practitioners do not have that conversation with adolescents. You know, we weren't taught in our curriculums how to do adolescent sex history taking. Maybe you all have because you're GYN and OB, but pediatricians and family practitioners, you know, they're not going to talk to people about, for example, rectal penetration sex. And parents aren't. Like I've asked parents, and they're like, "No, they're not having that conversation." But we all have to. In Maryland, it's actually legislation has banned LGBTQ sex ed. So I really honestly believe that these children, these adolescents could learn what HIV is, what syphilis, what chlamydia, gonorrhea, and how it's transmitted. We could see the number dropping. And also, I do test every single person from age 12 up for HIV because most of them have not been diagnosed either. But another thing, the labels, the asexual, bisexual, lesbian, gay, pansexual, poly, those are all labels, and I really want to encourage you not to use labels. So you're like, well, how do you find out about a person's sexual orientation? Well, ask them about relationship, and then ask them, the gender of their partners. So you're gonna say, tell me the gender of your partners, or tell me the gender of the people you are sexually attracted to. Because you'll get a clear idea of a person's sexual orientation if you do that. Now, for example, if you have a couple, a person that says I'm lesbian, you may not think to have a discussion about pregnancy prevention. Whereas if you ask the same person who identifies as lesbian, tell me the gender of your partners with an S, well, that person may say 3 women, 2 men, a transgender person. So, but why aren't you identifying as bisexual? Because I'm lesbian. I don't identify as bisexual. I just occasionally like having sex with male genital people. So try to stay away from the labels. And we're focusing on sex positivity. LGBTQ sex has been so immoral and improper that people are in the closet. And that's why, we see married guys, cisgender men, doing hookups or, meeting with cisgender men for sex, but keeping it secret because it's been so stigmatized. So if we support everybody and their sexual attractiveness, then it will be affirming. We call that harm reduction. Harm reduction. So also numbers of sexual partners. Lots of people now have multiple sexual partners. We no longer criminalize people. Harm reduction. Tell me where you're meeting your partners. Tell me where you're meeting your 15 partners that you had sex with. And if there's dating apps, harm reduction. Teach them how to be safe. Like, don't put your naked picture face on a naked picture and sext it to someone, or make sure a friend knows where you are. So just harm reduction, harm reduction. We're embracing everybody that what their sexual preference are and the type of sex they're having. But for adolescents, pediatricians say to me all the time, how do you do sexual history on a person that's like 10 to 13? Well, I'll say things like, so, do you have a crush? Do you like somebody? Are you holding hands? Are your lips touching? Are your body parts touching? And you really got to get to that place where you're comfortable asking those questions. Are you using your mouth? Are you using your front genitals or your back genitals? Things like that. And you'll be surprised once your adolescent patient develops a trust in you, then they will feel comfortable telling. Now, the one that I just saw before I came up here said, I'm attracted to female presenting people. So that could be a male that's female presenting, that could be a transgender female that's female presenting. But it's really important to get that information. And this person has been sexually active for a long time, and have had, anal penetration sex. So we're definitely going to do HIV testing. This is how you get HIV. Very important. Affirm them, be supportive, tell them that you're not going to have any conversation with their parents, and or I may not even write it in your chart, right? So don't forget, we're not labeling, we're asking people their sexual preferences, and we're asking people the gender of their partners. And I want you to think all inclusive. I want you to say, are you having sex with women, men, both, transgender people, or non-binary? So we're going to be all inclusive. So if a person says, I've had 2 female partners and a male partner, then you still need to ask, can you tell me their gender? Are they AFAB? Are they AMAB? Because you may find out that they're all AFAB, or they're all AMAB. So now we got to think in terms of all inclusivity. We're not going to assume because they said I have a boyfriend that it's not a trans woman. And so, I mean, because then you would have to do some pregnancy prevention, right? All right. And we're going to use gender neutral terms. Instead of saying breast, I would like for you to start using chest. Instead of external, we're going to say external pelvic. Instead of saying vulva, vagina. And we're going to say internal, genital openings, your front pelvic opening. Sometimes I ask, what do you call it? And they may say my manhole. Instead of pap smear, use words like cancer screening. Instead of bra and panties, you're going to use words like my underwear. And I'll usually say monthly or bleeding. Menstrual period is a really, 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 really strong source of dysphoria for people who identify as transmasculine. Right? So, and always think harm reduction. We're not shaming anyone. Tell me about your condom use. Do you and your partner ever use condoms? And almost 100% of my patients say no. And my trans LGBTQ patients, STIs and HIV are the top 3 health disparities. So I really do have to address it every single time I see it. So then you're going to empower them. You tell me how you're going to be safe then. And some people will say, well, we'll come get tested first. Always have the prep talk. So we can start an HIV medication if you're HIV negative that will protect you. But harm reduction is teaching them about what these infections are and how to prevent it. We're not shaming it. Like, how come you're not wearing condoms? You got gonorrhea again. Oh my goodness, that's shaming. We're not going to do that. We're going to treat them. We're going to affirm them. We're going to empower them to find a way that they're going to be safe themselves. At the bottom, since you're going to be seeing transmasculine people, then, I want you to ask them about their sex, their uh, their 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 sexual habits and their sex drive. That's the word I'm looking for, sex drive. Because testosterone drives that sex drive so high that it's that same part of the brain when you're hungry, you stop everything to go eat. And I'm seeing more of them. We call it forced sex. Forced sex. So, I'm feeling affirmed. I got a deep voice. I got this beard now, and I'm hooking up with guys, and we're bragging on the dating apps. I can take it in the behind, and then we get together, and it's uncomfortable. But now I'm not comfortable telling you to stop. These are the type of conversations I want you to ask. Because you're a male and you're gay, you don't have to be a bottom. These are the kind of things. Get comfortable with these conversations. But the sex drive is so high, please check in every time. I've had to actually lower testosterone doses for some of my guys. Sex positivity, encourage sexual pleasure. And you're going to get these slides, so you're going to be able to look at them later. And a lot of them are informational. I'm going to probably skip a lot of them though. PrEP, don't forget to talk about that. Chemsex and dating apps is very big in the LGBTQ. Alcohol and the poppers, they all make them very vulnerable to having unsafe sex. I want you to ask those questions. Tell me about drug use and alcohol use in your sexual habits. All right. I don't think we have any questions so far, but let's jump in. This is the reason why you all signed up for this. So transmasculine patients and genital bleeding. This is a really serious problem because, again, spotting and menstrual bleeding and periods and cramping and PMS are extremely triggering for patients, for transmasculine people. Do the same workup you would for anybody else. Testosterone does thin the lining of the uterus, but you still can have some activity there, some cells growing and dividing. Therefore, when testosterone levels or when testosterone doses get too high, they can aromatize in that endometrial and myometrial tissue to estrogen. So if that patient is coming to you and their testosterone levels are way in the male ranges, let's say it's 600 or 700, but they're having a period, then you always need to check their testosterone levels and their estrogen levels, because the number one cause for that is their testosterone dose is too high and it's converting to estrogen. And anything over 50 for estrogen, and I usually do not let my patients' testosterone levels go over 1,000. You'll almost always see it aromatized. Now, strong family history on people over 40, you still got to rule out hyperplasia and cancers. Testosterone does not cause the endometrial cancers. It's usually genetic or DNA. But we still do endometrial biopsies. Do not assume that it's this. Cervix, the vagina, the mucosal walls become very friable because testosterone really does cause atrophy. And I mean atrophy like a postmenopausal. And so that atrophy can change the pH, the normal pH in the vaginal wall, and that can make them at risk of cystitis, cervicitis, vaginitis, urinary tract infections, and spotting and bleeding on intercourse. And with that kind of cracked skin, you got to make sure you teach them that that can be a way of transmitting HIV. So really have that condom talk, but make sure that they know that that increases their risk of HIV. They may call you on the phone with urinary tract type symptoms, like it's burning when I urinate. Well, that could be the acidity of the urine also, as they're urinating and it's hitting those areas that are cracked. The treatment for that is a little bit of estradiol cream. They're not going to want estrogen, but try to convince them that if you put a little bit of estradiol on like your fingertip, just rub it around those areas, especially where you're experiencing some burning. But you still need to do a urinary. You need to do UA dipsticks. You got to still rule out. You still need to do a vaginal exam and rule out infections. The top two infections: bacterial vaginosis and Candida. Oh, okay. I thought someone was asking a question. Sorry. All right.
Just me.
That's all right. And actually, the period that's our number one goal is to stop ovulation, and that can usually happen around the second month after we've increased the dose of testosterone to around 50 milligrams. It's not moving. There we go. The effect of testosterone on ovaries. People with polycystic ovaries, I mean, This is like one of the treatments for them. And we do see trans-masculine people with PCOS. They'll come to me already on metformin and treatment. The testosterone can shrink the follicles. And after about the 8th week, once the testosterone starts getting in more of the male ranges, it does suppress ovulation, which means they become amenorrheic. They stop having periods, which can be confusing. I can't get pregnant because I'm not having a period. That's not true. And I've seen trans masculine people get pregnant, not realizing that they could think that they could get pregnant. So you got to have a pregnancy that, pregnancy prevention talk with them. We're going to talk about birth control in 1 second. Now, if they want to get pregnant, which trans masculine people want to do, then they can stop the testosterone. It takes about 8 weeks to completely wash out the testosterone, and they will ovulate again. They'll start a period again, and they themselves can get pregnant, or they can donate an egg at that time. Again, the testosterone can cause that atrophy and a shift in microbiome, changing the pH. And so I usually have that discussion before I even start the testosterone so that they're not in total shock when this happens to them. So Alex, 22-year-old trans-masculine patient on testosterone for 4 years, presents with complaints of new vaginal bleeding. History, painless bleeding for 1 month. First noted after receptive vaginal penetration. Happens every month. Staining underwear. May not be associated with, and it may not be associated with intercourse. No urinary tract symptoms. Testosterone is 75 milligrams weekly, and testosterone level is 700. This patient is non-binary, identifies as pansexual, started their period at age 12, no history of STI, no contraception. Family history, denies history of bleeding disorders, autoimmune conditions, GU or GI cancers, and their sexual behavior is vaginal as well as anal intercourse. Right? So, what could be the causes of this genital bleed? Right? One thing that I do not want you to rule out, and that's pregnancy. I've had several patients who've gone to several GYNs. They've gone to emergency rooms complaining of this pelvic pain, and no one ever tested them for pregnancy. No one did any history asking about vaginal penetration, birth control. A lot of these patients have never had a pap smear, never been tested for GC and chlamydia, and they come back to me and I test them and they're pregnant. So always first rule out the medical cause. The number one, though, is testosterone aromatizing to estrogen, but do not miss a pregnancy. So the workup, would be the same as you would. Check the estradiol level. If it's greater than 50, it's probably aromatizing. And just slowly taper down on the dose. So if this patient was on 75 milligrams, that's 0.35 mLs. Just taper down to 0.3, that's 60 milligrams. Usually that's all it takes. Right? And the atrophy, we talked about this. You can use small doses of estradiol, the cream, the vaginal creams, just enough. But you really got to encourage them that it's not going to really be systemic, because they're not going to do it if they think they're going to feminize. Every now and then, I'll be able to get a person to take estradiol tabs, but almost never. And lubrication is really important, especially for vaginal penetration. UA, still going to do UA and culture. Please do a pregnancy test. Sometimes I'll do a pregnancy test even if the person denies being sexually active, especially adolescent patients. They're trying to hide it. TSH, CBC, I do GC chlamydia cultures, check testosterone, estrogen levels. And if those estrogen and testosterone levels are normal, that's when I go for pelvic sonograms. remembering though that there could be some genital dysmorphia. So if they're requiring the sonogram to do an intravaginal exam, then it may be a really serious problem. So you may need to bypass using the wand in the vagina. So suppression of the period, we can, first of all, testosterone, when the dose gets up high enough, it'll suppress ovulation. You can use progesterone, but only progesterone. Try not to use estrogen. I like using IUDs, or you can use Nexplanon. You can use the growth hormones, Lupron and Histrulin and Supprelin, which we do for our like maybe 9 to 12-year-olds before they even really start going through Tanner stage 2. When our young people get to Tanner stage 2, we do prescribe puberty blockers. We block their secondary sex characteristics. Then once they get closer to Tanner 3 or 4, maybe my patients at 13, I'll start them on testosterone to emulate that puberty of a 13-year-old. Once you start hitting puberty, you'll start losing them if we don't do something. If their voice is not dropping like other boys' voices are dropping, they'll stop talking. They'll stop coming out. If their butt and hips and they start getting breasts, you'll start seeing them going to school and coming out around families and friends. So we do that at Chase. Some people you could get to do estrogen and progesterone, but rarely. I wouldn't offer them anything with estrogen. You could make their dysphoria worse, and that could lead to suicidal thoughts. I do have people as young as 18 who are getting total hysterectomies and oophorectomies. Their dysphoria is so severe that we have to do something to save their life. We call that risk versus benefits. So, topical estrogens, surgical interventions, everything you would do to suppress anybody's bleeding. But the simplest thing you can do is lower testosterone dose. Reproduction, we have trans couples that are getting together. If the trans man is carrying the baby, we have people going to infertility centers and doing IUIs and IVFs. Just had a trans masculine guy who donated an egg, and they used donor sperm, and the wife is actually carrying their child right now. I see that all the time. The problem though is when these pregnant trans masculine guys with full beards, deep voice, very masculinized, have to go in and sit in these OBGYN centers that say well women, and it's all pink and people are breastfeeding, and those are all triggering and very it triggers the dysphoria. So we're trying to encourage not using words like well women, but like maybe pregnancy center or whatever they use. Ours is well health. I can't remember what we put Chase Braxton, but it's not. We don't say women. The effects on testosterone and fertility. Again, if you take away the testosterone, it washes out anywhere from 1 to 6 months. For me, it looks like it's around 8 weeks. It can cause severe birth defects in the child. So I really have to counsel them about that, not getting pregnant while you're on testosterone. Just like with birth control pills, suppose you're late getting that shot or putting that gel on, and that little egg gets through there, you're gonna get pregnant. The only time they can't get pregnant is if we prescribe puberty blockers before the egg matures, which we do, because we're saving the kids' lives. If the egg have matured and we start puberty blockers, then these kids they lose their option to have their own kid. And as you can imagine, that's really stressful for parents. So this slide, I encourage you to, to copy, because there's some great resources on taking care of pregnant prenatal care for trans masculine people. For contraception, my number one choice is IUD, and I have kids as young as 12-year-old that's getting testosterone with IUDs. There's not very many people that get pregnant, but we do see that view. I had a 42-year-old about 5 years ago that got pregnant and was so dysphoric that was in a psych ward and getting every 15 minutes suicide checks. So it's so important that we have that conversation about pregnancy prevention. And I'm gonna start moving it here because I still have a lot of slides. And in fact, I think I'm going to skip this one because basically this case talked about counseling a person who's trans masculine about pregnancy prevention. And so what we do is try to avoid estrogen, but we do progesterone, we do IUDs, you can do Nexplanon. No studies have really they've not done any studies really that tells what happens to sperm with estrogen, because there's not going to be many volunteers to do that research. So you always got to talk to trans females about, you can get your partner pregnant. We still use these contraceptives. None of my patients do. They just outwardly refuse. And it seems to be one of the things on the dating apps. If you use condoms, you can forget it. There's not gonna be any hookups for you. The female condoms are now called loose fitted. These condoms that you see right here are snug fitted. So you can still use the over the counter non-hormonal contraceptive methods. So these all are going to be on your slides that you'll get. Right. These are the female condoms. We talked about fertility. This is a trans couple. I see that all the time. And a trans man carries the baby. Sexual health. First, transgender people identify with almost every sexual orientation. But the two that you may hear often is asexual and pansexual. I get asexual does not mean not sexual. It could mean that you have genital dysmorphia. And so I may sex you, go have oral sex on you, but I rarely go into the bathroom and uncover myself, not even for showers. So you'll never touch me. So if you're not asking about sexual behavior, then you could miss an opportunity to check throats, for example, for chlamydia and gonorrhea. Once people really start affirming their sex, their gender identity, things start looking the way they feel on the inside, and they're comfortable in their affirmed walk of life, then we see a shift in sexual orientation. Sometimes we'll see trans masculine people who are only attracted to females, assigned female at birth, now wanting to have sex with guys. And so again, that's where you have that conversation about forced sex and about not having to be a bottom, and really check in on that sex drive because it's off the hook. All right, so this all of these are the studies that support what I just said. And pansexual is another one that they will identify with. So that means I'm attracted to or I have sex with people of all genders and sexual orientations. Now, these are all AFABs. These are all assigned female at birth. The couple to your right, these are two transgender men. The one in your middle, that's a gender non-binary male and a trans male. Your couple on your left, that's a lesbian couple. Christian, is everything okay?
We have a question, and I apologize.
Oh, okay.
A few minutes ago.
All right.
The question, what type of pre-procedure meds prep for younger people for IUD insertion? Misa?
Oh, I'm getting ready to go through a whole section on that. If you want to hang tight for a minute. All right, yeah, I got this down pat. So yeah, we're gonna go through that. Just one second. All right, so these are all AFABs. The do you do, the V to V stands for vaginal to vaginal sex. Now that's skin contact. That's no two mucous membranes. So there's no urethra touching vaginal mucosal or rectal mucosal or oral mucosal. These are two skin to skin. And it's referred to as scissoring or grinding. It's clitoris to clitoris body fluid exchange. Any guesses on what the number one STI is for people who have V to V sex? Any guesses? All right. The number one is HPV, the human papillomavirus. But of course, other skin to skin contacts, syphilis, herpes. You can see herpes. I've rarely seen syphilis. You don't see chlamydia and gonorrhea. There's no mucous membranes involved. It's just skin to skin. But the thing that's important to know about this, because you know HPV is one of the common causes of cervical cancer, these people have to have cancer, cervical cancer, like the pap smears. I'll just say pap smear. I don't say that in front of them, but and they don't. No providers are telling them that they need to get cancer screenings or pap smears. And so I'm beginning to see quite a few transmasculine people with abnormal dysplasia and or usually diagnosed after it becomes metastatic, which is even sadder. So it's really important. But if you can imagine, if they have gender dysmorphia, then it's going to be difficult for you to get them on stirrups and to be able to do a speculum exam. So we do allow them to do self-collecting HPV or self-PAPs. Go in the bathroom with the swab. Actually, let's show you. I may cut this off soon because I only have 15 minutes with you.
Looks for HPV, a common infection. Testing for HPV can help protect you from cervical cancer. It's okay to be nervous. Remember that this is a safe and effective way to have a cervical screening test. If you need extra help, just ask your healthcare provider. They can give advice without looking. If you think you've made a mistake, let them know. You can start again. When you've been given a private space, find a place where you feel comfortable. Without opening it, have a look at the self-collection swab. It might not look exactly like this one, but you should see one end that you can hold and another end for taking your sample. First step is to pull down or take off your underwear. Now, twist the cap and remove the swab from the packaging. Be careful to only hold it by the cap and don't put it down on anything. If you accidentally drop it or the swab touches something, you can ask for another one. The swab has a line or a mark to show you how far to insert it. Gently insert the swab into your vagina a few centimetres up to the line. Rotate it gently for 10 to 30 seconds. This might be a bit uncomfortable, but it shouldn't hurt. Remove the swab, replace it in the packaging, and seal the whole thing up. And that's it. You're all done.
Now, for me, we use the same swab that you use for the cervical pap. We have them go in the bathroom. We have this diagram on every wall in every bathroom. They go up till it stops, twirl it, and then sweep coming out and use the same container you would for cervical. But you just got to let them know that you're looking for HPV, that it may not be endocervical cells. And then the D, that's for digits, dildos, toys, things like that. When, what we do with harm reduction is we teach about cleaning in between taking condom off, putting the condom on before you use it on each other. but they commonly called strap-ons. But we're not seeing sexually transmitted infections even being transmitted with these. I do want you to check throats. For MSMs, we're seeing a lot of beginning to see an increase of throat cancers from HPV. Just check throats, check lymph nodes. That picture on your left, that's not thrush, that's HPV. That picture in your middle, that is a wart back there. They go to dentists or oral surgeons. I don't send them to ENTs though. You can see rectal anal carcinomas. So the ASCCP, I'm not sure, maybe the GYNs can tell us if they're recommending anal pap smears for people who have abnormal cervical pap smears. But we check everybody who's HIV positive. We do anal paps. I'm gonna probably
Open the anal cytology collection
we're gonna speed through this.
in the lithotomy position, or for a digital rectal exam with anal exposure, always perform the anal pap before a digital rectal exam. Moisten the flock Dacron swab with water. Insert the moistened swab until it bypasses the internal anal sphincter and abuts the distal wall of the rectum, approximately 1 to 2 inches. If using brush, no moistening necessary. Use the external sphincter as a fulcrum. Rotate swab in a circular fashion and continue to rotate as it is withdrawn to sample cells from all aspects of the anal canal. Swab should bend slightly with gentle pressure. Count slowly to 20 while collecting. Rinse the swab in the collection vial by rotating in the solution 10 times. Swirl the swab vigorously. Discard the swab.
And so we use, the same cervical pap container, but you just put screening for rectal cancer. We're doing this big campaign now where we have posters. If you got it, check it. It looks like this. Again, most people are not aware that they should be referring transmasculine people for cervical cancer screenings. And that's what all of these slides that I'm flying through are discuss some studies that kind of support doing the self-pap smears. All right, and then other things that increase the risk of cancers are smoking, alcohol. These are all things that people do to self-medicate. Right, and then prevention, of course, the HPV vaccine and getting your cervical cancer screenings. All right, so making the pelvic exam accessible to answer your question. So one of the things I really want you to be aware, conscious of, is that 50% of transgender people have experienced some type of sexual violence. And I'm talking about through healthcare providers in healthcare settings. I have patients that was like, I told them to stop, but they told me to relax, act like you're having sex, and they just crank it up, they're not, respecting their wishes. And so, of course, these people are never going to come back. They need to regain our trust again. But I do want you to check in about sexual trauma. And because if they have sexual trauma, refer them to behavioral health first. This is a great site here. What we do is we allow people, so way before they come in for their, whatever the procedure they're going to get done or their cervical cancer screening, we ask them, do you need a Valium? Do you need some type of benzo? You bring your big over the ear headphones and blast rap or blast, rock and roll or whatever you like, heavy metal. We do allow people to bring friends with them that will help them stay calm. If you want to burn incense, like whatever you want to do. But we do make it very comfortable for them. Like we make the room very affirming. And we ask them to tell us if it starts to get uncomfortable, is there a safe word? Like, it's getting too uncomfortable, and then we'll stop. Or do you want to watch? Or exactly how would it make you feel more comfortable? But I give them a gown for the front that opens in the front, a gown that opens in the back. Lift up, do your exam, make sure you tell them every step of the way what you're doing. So I'm going to touch you here, I'm going to touch you here, I'm going to touch you here. And then, the same thing with the PAP. Usually my patients do not want chaperones because they're very concerned about that dysphoria. And sometimes it can take me up to a year before I can actually do that first one. We do have gynecologists that will do these under conscious sedation. So if we're still unable to get a self swab, if we have a 12-year-old that's too uncomfortable to get the IUD, which I've not seen, all of them have been fine. Like our gynecologist is just experts at working with them and talking them through it. Then we can refer to GYN who do conscious sedation. Make sure you're asking them what they want to call their parts. Don't try not to use like vagina, vulva. Those are all very tricky for them. And the last thing, you may be seeing some of these trans-surgical surgeries on these trans-masculine people. I'm seeing more and more people who identify as male who are keeping their vagina, uterus, ovaries, all of their internal, and are getting phalloplasties. So they still have to have pap smears. So if they've had bottom surgery and they have a phalloplasty, the other one's called clitorioplasty, then you got to ask them if they've had a hysterectomy, because you still will have to do cervical cancer screening if they kept their vagina. Most people, though, they do get a vaginectomy and they get total hysterectomies. The metoidioplasty, the picture on your left, you can get some clitoral hypertrophy or enlargement because of the testosterone. So it's a surgery that's a pullback. So the clitoral ligament is divided and the clitoris becomes a phallus and the labia becomes the skin covering for scrotal implants. The urethra is actually rerouted so that they can stand to urinate. The phalloplasty, full thickness skin graft from the forearm. Some people use the anterior, external, lateral thigh. That skin becomes the shaft, the picture you're seeing C. The tube that's coming out of the urethra, that's part one of the surgery, the whole of the urethra open. That you see a suprapubic tube coming out of there also. So that's part one of the surgery. If you look below the shaft, you can see that there's a hidden clitoris and urethra. Some transmasculine people choose to leave it there. Others have them rerouted through the shaft. And part D is the glandsplasty, and that's when they remove the suprapubic tube, and then the urologist reroutes the urethra. So I'll try to give you some more time. Are there any more questions?
I don't see any questions at this time, but please feel free to submit your questions to the Q&A box, chat box, or use the raise hand feature and you can speak directly to Deb. We can pause, or if you have more slides you want to go to, I don't know.
Right. So yeah, I did add a whole bunch of extra slides just for educational that you can read through later. Some more information about how to make your patients more comfortable during these exams. But I really do hope that you will open access of care for our trans community because they just don't have it.
So we do have a question.
Okay.
Do you have any advice about getting patients' hormones or PrEP covered via insurance?
Well, at Chase Braxton, we seem to be experts at that. We have called the Power Clinic. and they are amazing. They're even getting the injectable PrEP covered. And we are also prescribing PrEP for adolescents, because the law in Maryland says we can prescribe PrEP without parental consent. And so, that's challenging because it can't show up on their insurance. Adolescents, how they're going to drive to the clinic. But they've pretty much perfected that. You may want to reach out to your local health department. They may have vouchers. Usually they have PrEP clinics, and they can probably advise you best about how to get the PrEP covered. You could also call Gilead. Gilead has a lot of coupons that they give also. But please prescribe PrEP because trans women, 1 out of every 50% of trans women are HIV positive. And, it's sad to say, but if you see a trans woman, and I really would love it if you saw our trans women who have vaginoplasties, like, if you're not looking for a cervix, but you are going in. I use an anal scope looking for granulation tissue. You can, you won't see GC chlamydia or cervix, but I would love it if you start seeing trans women.
Wonderful. That's great. We also do have a talk on PrEP if anybody wants to learn more. Next question. Any advice re DEXA scans in older trans male?
Well, yeah, I started doing DEXA scans at the same age I would anybody else, but if you're a person has had puberty blockers, right, where there's no hormones, during that puberty phase, that's when you get bone development. And so those we monitor, we do DEXA scans on them annually. We prescribe calcium, vitamin D, and weight-bearing exercise. But if your transmasculine guy has had a total hysterectomy to include oophorectomies, and they've stopped taking their testosterone because they can't feminize, then you really need to be concerned. And I would start doing DEXA scans on them. But DEXA scans anytime you would do anybody else. But for them, especially if they stop taking any hormone, then there can be a problem with osteoporosis.
Thank you. All right, I don't see any other questions, but a few people had to run. They said thank you. This was great.
Awesome.
But we'll still pause. Just a reminder, while we're waiting for last minute questions, that your CME survey is going to pop up after this presentation when you close out of the webinar. Please complete that.
I will put my email. I'll put an email in here if you ever, because I have at least 3 GYN lectures that I do.
Thank
so
you.
I will put my.
Great.
Yep. Just reach out anytime. Thank you. Thanks for saying that.
Oh, good. You saw that comment. I was hopeful you
Yeah,
did.
thank you so much.
All right. Well, we will end here. Deb, thank you
All
so
right.
much for this
Thank
presentation.
you.
I
Take
always
care.
look forward to
Have a
your
good
talks. This is great. And thank you all for
Awesome.
joining us today.
Take care.